Okay, here we go. So integumentary systems and problems with the skin. So your skin, the function is protection, right? It protects protection of the underlying tissue is its primary function. It provides a barrier for against bacterial and viral infections and excessive water loss. Insulation and protection from trauma is the role of the subcutaneous layer, so the layer with the fat in it. Sensory reception, so this tells us if we're hot or cold. We can sense vibration through our skin. It controls temperature through vasoconstriction and vasodilation. Right? If we are too hot, we vasodilate, so our vasculature gets closer to the skin area so we can lose the heat. When we're cold, we vasoconstrict, right? That's why we put cold on areas to decrease swelling. And it helps it's also responsible for insensible water loss. So you can lose up to 1 liter through perspiration. Actually, even more if you're excessively perspiring. It helps maintain homeostasis through fluid and electrolyte balance. It's has lubrication through cerebrum and sweat, and it's responsible for vitamin D synthesis, right? So that can help with calcium and phosphorus balance in our body, especially as we get older and our patients are at risk for osteoporosis. They need a certain amount of sunlight so that they can synthesize vitamin D, and vitamin D is needed for the uptake of calcium. It also is responsible for a lot of personal identity through pigmentation. And when we talk about certain pigmentation diseases, we'll discuss that briefly. So it's the largest organ in the body. It accounts for about 15% of total body weight. It's comprised of skin, hair, nails, and glands. It has 3 primary layers. So structurally, the epidermis is the outermost layer. It's replaced about every 28 days. It's about 0.5 to 1 millimeter in depth, and there are no blood vessels to this area. So if you receive a laceration or something, then you've gone through the epidermis, right? It is kind of the protective barrier and folds into the dermis. The dermis is the middle layer. This contains dense connective tissue. The papillary layer is makes up fingerprints with the epidermis. The reticular layer contains collagen and elastic fibers that give it strength and elasticity. And the fibroblast cell type is important in wound healing. This is highly vascular, important in regulating temperature. We talked about vasoconstriction and vasodilation, and blood pressure by the support that it gives the nerve and vascular networks. It also contains elastin, nerve cells, lymph cells, hair follicles, sebaceous, and sweat glands. And the subcutaneous tissue, this is the innermost layer. It consists of soft fatty tissue, blood vessels, nerves. It provides insulation, helps control temperature, can be a shock absorber for trauma. And this is where we store some lipids, right? It is distribution, varies by sex, heredity, age, nutritional status. So because it's low in the layers of the skin can become important when we get to burns and determining the degree of burns, right? So to assess the skin, we need a past health history of any trauma, any surgeries, diseases involving the skin. Have they ever had any issues? Skin problems related to other diseases. So cirrhosis of the liver disease can cause jaundice or yellowing of the skin. So this will show up there. Any history of diabetes. Diabetes can impair wound healing and potentially nerve damage, which can lead to pressure ulcers. Do they have any allergies? How's their sun exposure? Are they sun people? When we talk about surgeries, have they had any cosmetic surgeries, any biopsies? Did they have any skin biopsies taken? What were the results? Have they had any radiation therapy, any laser peels, anything like that? So the general principles for an integumentary assessment is we want to maintain privacy and adjust lighting and room temperature so that the patient is comfortable. We want to do an assessment from head to toe approach and side to side. Is it symmetrical? Do we see any, if we have any lesions or disruptions in the skin, are they symmetrical? What do they look like? If we find any lesions, rashes, or breakdowns in skin, we need to thoroughly document them, and potentially pictures may be necessary to document their presence and to document the progress of treatment. We need to use the appropriate language or nomenclature when describing lesions, and we'll talk about that a little bit more shortly. So when we inspect, we're looking at the color of the skin. It depends on pigment. Pigmentation can make it more difficult to assess for things like paleness. If we have abundance of melanin and darker skin, we want to assess for paleness in the sclera of the eyes. You can pull the eyelid down and look in there. It should be nice and pink. You can look at the oral mucosa, how's the coloring of the gums and the inside of the mouth. Look at the palm of the hands, right? We want to look at, assess for any problems related to vascularity, any bruisings, and angiomass, petechiae, any purpura, anything like that. We want to check for any unusual color. Woods lamp may be helpful in this. A Woods lamp is almost like an ultraviolet light that can show kind of unusual patterns in the pigmentation. We want to assess for and look at the hair distribution. Again, this can be signs of other issues or side effects from certain medications. If we go to heratism, certain medications can cause heratism. We want to look at the nails. You want to palpate the skin. How's the temperature? Are they cool and clammy? Are they dry and hot? How's their skin turgor? This is the elasticity of the skin. Dehydration can be a sign. And where do we check for skin turgor? Most people, you don't want to do the hands, and you should do the chest wall and see if there's tenting. Moisture, we want to assess for does the skin look well hydrated? We're not talking now about necessarily diaphoresis, but as we get older, our skin tends to get drier. So we want to take that into consideration. What's the texture of the skin? Do we notice any calluses? When we talk about lesions, whether they're flat or elevated, will change the type of lesion that is, right? So we talked about that. Darker skin can be more difficult to assess for certain deformities, but we can look at the mucous membranes, nail beds, palms, lips, sclera. We want to palpate any rashes and see if they're flat or elevated. Rashes may be more difficult to see in people with darker skin. People with darker skin are also more susceptible to ingrown hairs, keloid formation. This is kind of the bulking up of scarring. Mongolian spots. These are kind of benign, bluish black, flat Macules often at the base of the spine. These are not a sign of abuse. It's just a normal coloration. They may get nova odas. These are blue-gray birthmarks on the face, or sclera from the entrapment of melanocytes. And they're also susceptible to vitiligo. So vitiligo is the loss of pigmentation, and it can start as patchy losses of pigmentation, not contagious, right? So primary skin lesions, we're going to talk about macules. So macules are a circumscribed flat area of color change. So it's a color change that is, you can't palpate this lesion, right? They're less than 1 centimeter in diameter. That's and they are examples of these are like freckles or flat moles can be just described as these. A papule, this is an elevated solid lesion, less than 1 centimeter. Examples of these are warts or moles, can be a papule. And a vesicle, this is a circumscribed, so circular fluid-filled sac. It's less than 1 centimeter. Examples of these can be varicella, your chicken pox, or a vesicle rash. And zoster, so herpes zoster can cause shingles, and second-degree burns can cause these little vesicles or larger blisters. So plaque, this is just a elevated, solid, and superficial. It's more than 1 centimeter. Examples of this are psoriasis or keratosis. Keratosis is just kind of a hardening and thickening of the skin. The psoriasis is kind of red, scaly disease, right? Wheal, this is kind of a firm, edematous, irregular shaped. These can vary in size. Examples of these could be insect bites or urticaria. Pustules, these are elevated, superficial. These are purulent fluid inside, so usually a sign of an infection. This can be, examples of these are acne and impetigo. A fissure, this is a linear crack, epidermis to dermis, so it goes through the dead layer of skin and into the dermis. They can be dry or moist. Usually they're a result of dry skin. Examples of these are, oh God, that's right in my way. So these can develop over time as a result of, it can be the result of an infection or just drying of the skin. So you can get the purslane, these are the inflammation, the sides of the lip and corners of the mouth. And these are caused by fungal or bacterial infections, and they can cause cracks into the dermis. Athlete's foot can cause this. And excessive, you may see these in some diabetic patients as well. And the healing becomes more of an issue if the patient has diabetes. So you can have secondary lesions, you can have scales. This is excessively dry skin that frequently sheds. And examples of these are tinea, so that's ringworm, which is a skin infection. You can have flaking of the skin after a drug reaction, can cause these kind of scaling. Scars, these are just abnormal connective tissue that replaces normal skin, usually is a result of healing. Keloids are an extreme form of scarring and actually cause a buildup and raised scar area. And examples of scars is we have them after surgical wounds, some lacerations, after a bunch of different things, right? Another secondary lesion we can have is ulceration. This is loss of dermis or epidermis. They can be caused by venous insufficiency. These are usually shallow and irregular, or they can be a loss of arterial circulation, so arterial stasis. These are usually deep and round. Examples of these are diabetic pressure ulcers or arterial stasis ulcers. You can have atrophy. This is a depression in the skin from thinning of the dermis and epidermis. Examples of these are striae, so you're commonly known as like stretch marks, steroid-induced thinning or aging of the skin. Other issues we can have is excoriation. This is areas of the epidermis has been removed, exposing the dermis. This can happen from scratching or abrasions. This actually looks like the picture you have here looks more like a fungal infection. But the treatment is best practice is to cover the wound, identify and treat the underlying cause, prevent secondary injury from a primary lesion. So if you have pruritus or pruritus, just an itching of the skin, so the scratching can cause it. So scratching, we shouldn't be tearing at the skin. You can have them tap at it. Oftentimes cool tap water will help with itching, but we want to avoid that secondary injury. So lesion assessment, if a lesion or rash is found on the skin, we always want to describe the color, size, distribution, location, and shape of what we see in our documentation. So here's some nomenclature that you may want to know. So you can have annular. This is kind of ring-shaped. You can have a iris lesion. That's iris, not Irish. Lesion, which is kind of a bullseye. You can have a linear distribution. Oftentimes you'll see these along a dermatome with like shingles. You can have nomular, which is kind of coin-like. Polymorphous means that they have multiple forms, scattered, right? So just make sure we're using the proper words to describe these. Oftentimes in your chart, you'll be able to, an electronic charting, you'll be able to right-click and get an explanation of the stuff that's there. So what's the distribution of the lesion or rash? Is it symmetrical or unilateral? So is it one side, asymmetrical or unilateral? Is it symmetrical or bilateral? Is it confluent? In other words, if these merge together, are they diffuse, which is kind of a wide distribution over a large area? Generalized is all over. Grouped may be in clusters. Solitary is a single lesion. And symmetric is the bilateral distribution. We said that. So there's a list of common abnormalities here. You should know these terms, right? Alopecia is the loss of hair. Angiomas is a tumor that consists of blood vessels and lymph vessels. Carotenemia is the yellow discoloration of the skin, also may be called jaundice. Cyst is a fluid-filled sac. Vitiligo, loss of pigment. Ecchymosis is bruising. Erythema is patchy redness. Hematoma is an extravagation caused by swelling. Hirsutism is male distribution of hair in women, so facial hair. Vitiligo is the loss of pigmentation. What else do we care? So make sure you look these up. Moles are just the benign outgrowth of melanocytes. Petechiae is pinpoint deposits of blood, so little pinpoint rashes. Vitiligo, petechiae is never normal and should always be investigated further. Solar lentigo, this is your liver spots secondary to age and sun exposure. and usually benign. As we get older, we have some changes in our skin. We have elastin degeneration, which results in wrinkling and sagging of the skin. We have decrease in extracellular water, which causes dry and flaking skin. Decrease in glandular activity, so we may have a decrease in swelling, which would make us more prone to heat exposure. We have increased capillary fatigue, so we tend to bruise more easily. Increase in melanocytes, so that's the senile lentigos, or your liver spots, or age spots, depending on which sort of term you want to use. If we have decreased blood supply, so we tend to get pale, cooler. We have a less tolerance to cold, decreased tactile responses. And we have a decrease in cell proliferation, so we may have a decrease in healing or a longer time for our wounds to heal as we get older. So diagnostic procedures depends on what we're seeing. So they may do a biopsy depending on the lesion. They can do a punch biopsies where they just for small little lesions, or they can do a excisional biopsy for wide margins used if they suspect melanoma. May have to suture those sites back up after removing them. They can do shave biopsy where they just kind of shave, the razor shaves off the lesion or a piece of the lesion for biopsy. If we suspect a bacterial or fungal infections, they may do a swab, do a culture of the area, so stains and cultures for fungals and nail infections suspected, skin infections if there's drainage, right? They can do patch testing for allergies. They may do several different areas if we're looking to see what somebody's allergic to. They have a bunch of different areas. You probably went through that in your fundamentals class. So the skin reflects both physical and psychological well-being. So we need to protect ourselves from sun exposure. So premature aging, loss of elasticity, thinning, wrinkling, and drying of the skin can happen from unprotected sun exposure. Tanning is the skin's response to injury. So that healthy tanned glow you have is actually damage to your skin, right? We need to, certain drugs increase photosensitivity and can exaggerate burns. Elavil, Cipro, Lasix are some of the meds, right? So we need to avoid that. If we are going to be out in the sun, we should be using sunscreen. Having a healthy sleep rest pattern increases the circulation rest and sleep is restorative, and getting enough rest and sleep is important. Exercise can increase circulation. We need good hygiene and nutrition, and proper self-care and hygiene practices. That kind of went a little small. So talk a little bit about skin cancer. So non-melanoma, this is an solar keratosis. It affects nearly all the older white population. It's the most common form of precancerous lesions. The appearance is highly varied, but irregularly shaped, flat, slightly erythematous papule with distinct borders and an overlapping hard keratin scale or horn. So it'll be kind of a slight discoloration and a little hardening of the skin over it, kind of dry patch. It's pre-malignant and puts us at risk, but it is not a skin cancer. It's a precancerous lesion. Basal cell carcinoma. This is occurs in middle age and older adults. It's locally invasive malignancy arising from the epidermal basal cells. It manifests in a pearly papules, most common but least deadly form of skin cancer. So this happens quite often, but usually it's just an incision and removal, and we're good. Squamous cell carcinoma, this is a less common than the basal cell. It's rough, scaly lesion that may bleed. It's ulcerations and crusty. It's aggressive and has potential to metastasize and lead to death if it's not treated early and appropriately. It's diagnosed by a biopsy, most often caused by skin exposure. And tobacco use increases its occurrence around the mouth and lips. Malignant melanoma, this is a tumor arising from the melanocytes. It's increased incidence in people with fair skin, light-colored eyes. It is the most deadly form of skin cancer. Incidence are increasing faster than other forms of cancer. It is responsible for about 40,000 deaths worldwide. Risks include chronic UV exposure, fair skin, genetics, and some environmental hazards. 1/3 occur in existing novi or moles. And the best advice for prevention is to avoid excessive sun exposure. If you must be in the sun, use UV protection and limit your time to direct UV. Don't go out unprotected. So this just shows some picture of asymmetrical borders in certain malignant melanomas. And again, some more pictures of malignant melanomas. This is just a chart that kind of goes over the pre and malignant skin cancers, what they look like, and their treatment and prognosis. So this might be, if you're like me and like charts, this may be helpful. So infections of the skin, there's 4 broad categories. They include bacterial infections, whether they're primary or secondary, viral infections, fungal infections, and infectious or infestations and insect bites. So infestations and insect bites can be bites from bugs. You can get scabies, which is an infestation under the skin. Yeast infections are tinea yeast. Viral infections is herpes, warts, that sort of stuff. Your primary infections, bacterial infections, maybe MRSA. You may get an infection secondary to the treatment of your infection that are often thrush, so no overgrowth of candidus, something like that. So your bacterial infections, if you like charts, here they are, and we'll describe each one here a little bit as we go along. So cellulitis is just an inflammation of the subcutaneous tissue. The inflammation may be secondary to complications of or primary infection following the break in the skin, so it depends. Staph and strep are the most common causative organism of your cellulitis. You'll notice in these pictures that there's no really collection of purulent drainage. It's kind of a widespread inflammation infection. So this is impetigo. This is associated with poor hygiene and poverty. This is very contagious. With any of these contagious diseases, we want to use a new washcloth every time. Don't share towels. Perform good hygiene when washing the area. We want to use cool or warm, not hot water to wash it. Um, Other infections that we've seen quite a bit of is MRSA, whether it's community or hospital acquired. MRSA infections usually start small and spread. The surface appearance may be misleading, and you may have a much deeper, a much bigger infection than you think because most of the infection may be below the surface. Treatment and choice is an incision and drainage, followed by antibiotic therapy, depending on the type of, whether it was hospital or community acquired, maybe different antibiotics. It can spread, it can become respiratory and systemic forms. About 1% of the population is colonized with MRSA in the nares, and 33% of the population is colonized with Staph aureus, although it may not be methicillin resistant. So viral infections, there's herpes simplex virus 1 and 2, which are lifelong, recurrent, exacerbated by stress, sunlight, trauma, menses, systemic infections. It's transmitted by respiratory droplets or virus-containing fluids. Zoster, herpes zoster, this is your shingles. This is a frequent in immunocompromised patients. Contagious to anyone who has not had varicella. If you've not had chickenpox, you are potentially could catch zoster. The varicella, Vercula variegalis. This is a papular raised hard lesion. It is caused by HPV. It's a compound, W-salicylate acid is used to treat it. They may do cryotherapy or shave the lesion. Plantar warts are another. These are a wart on the bottom of the foot that's growing inward due to the pressure of walking, and these are quite painful. And the treatment is similar, so you can do the cryo, the shaving. You usually see a podiatrist for that. Here's a picture of your herpes virus infection of the lip. This is typical presentation. It's called canker sores if they're inside the mouth or on the tongue. Fever blisters or cold sores on the outside. And then they may be followed by a viral infection. So this is your herpes zoster or your shingles. See this? You'll see the linear distribution along the dermatome is the classic sign of this. It's usually unilateral on the trunk and face, and in the lumbar sacral areas. You may see occasionally where it's bilateral, right? The treatment for this is antiviral agents, and Neurontin may be helpful for pain because it causes nerve pain. It runs along the dermatome, nerve pain. There are vaccines available for adults over 60 who have had the chickenpox. Having had the chickenpox puts you at risk for getting shingles. So fungal infections. Again, if you like charts, here they are. The Taenia corpus is ringworm. Taenia crucis is what we commonly refer to as jock itch. You can have Taenia eugenism, that basically your toenails, the fungus in the toenails, and Taenia pedis, this is the athlete's foot. You can get fungal infections, just Taenia interrigo, this is in the folds. You see this quite a bit in hospitalized patients, especially patients on antibiotics, where you get kind of this, it's warm and moist in this area, and a great fungus loves that, and it'll just take over. Treatment is to keep the area dry. They may use antifungal powders. Don't cake this on, and don't, when you clean it, you don't want to rub vigorously because you'll take off any healing skin, but you do want to keep the area clean and dry. And again, just this could be very itchy, very bothersome. So pictures of fungal infections in your toenails. These can be difficult to treat. It often occurs with, it's often worse with poor circulation and not as responsive to therapy if you have circulatory problems. They can do topical or systemic medications, and it may end up losing the toenail. Other infections of the skin and hair that you may have, you may get insect bites or infestations, so bee stings and wasps, which are usually uncomplicated unless you have an allergic reaction. But keeping the area clean and avoiding secondary infections are huge, so we don't want to be scratching the area, opening that up, and getting a secondary infection. Bed bugs can be a problem. You'll need to usually get rid of the bed altogether. They say you can cover it in plastic, and I forget how long you have to leave it there, but you get rid of the bed if you can. Where was I? This is lice. So head lice is treated with a antiparasitic like shampoo. It's Rid-X, Rid-X is for your toilet. Rid, they use for this. So you put the prescribed, you can actually buy it over the counter, medication on your hair, leave it sit for the prescribed amount of time, and then often you'll use a very fine comb to comb out the nits. Nits are the little eggs that the lice lay in your hair. This is highly contagious. It is not a sign of poor hygiene. Risk factors include going to daycare or school. Obviously, anybody who has lice or scabies, you'll need to not share towels, use a new washcloth and towel each time. All the bedding needs to be cleaned in hot water and dried at a high temperature to kill off any infestation. Don't share combs, don't share washcloths. Even things like putting your head together. Oh, aren't you cute? And now you're infected. Scabies is kind of an infestation under the skin of mites, lay their eggs under the skin. It causes severe itching, red papules. It can be crusty. They give you so the RX is 5% permethrin, and then you'll apply it all over, and then again in a week. It is best applied after you take a nice warm shower and you dry off, but your skin is still moist from the shower, so it penetrates better into your skin and you get better parasite killing properties. Certain diseases can cause dermatologic manifestations. So endocrine problems can, like diabetes, can cause skin problems and healing. Excuse me. So you should know the manifestations based on each disease process. Not for this test, but moving forward, know that some changes in the skin are not necessarily a primary integumentary problem, but a sign of a systemic disease that's manifesting in the skin. Hope that makes sense. Some of these manifestations we have listed here. So diabetes can have decreased wound healing. Hepatitis can cause jaundice. Scleroderma can cause leathering or hardening of the skin. Lymphomas can cause papules, nodules, or plaques. Peripheral vascular disease can cause dependent Reuter, and meningitis can cause petechiae. Remember, petechiae are never normal, and you always need to have this evaluated further to find out what the cause was. So this is a picture of petechiae, just those little kind of pinpoint hemorrhages, for lack of a better word. And again, never normal, always needs infected. Benign skin conditions are listed here. We're not going to go over these too much, but acne, novi, these are moles, Psoriasis, that's the chronic dermatitis with rapid turnover of epithelial cells, causes scaly plaques on the elbows, knees, palms, and soles. While it is benign and non-cancerous, it still may require some treatment. You have skin tags, lipoma, which is just a benign tumor of adipose tissue. If you ever watched Dr. Pill Popper, she loves herself a good lipoma. Vitiligo, again, is the loss of pigment, and the lentigo is the liver spots or discoloration of the skin. Here's your picture of psoriasis. Psoriasis is a chronic autoimmune dermatitis with the rapid turnover of the epithelial cells and the overproduction of keratin. It's associated with rheumatoid arthritis. It may have a family disposition to it. It can be exacerbated by stressor hormones, seasonal changes. It's characterized by periods of exacerbation and remission. The treatment is usually topical steroids. The side effect of these topical steroids is that over time it can thin the skin. Topical meds that suppress acceleration of epidermal growth are not recommended for older people. So the cytotoxic agents such as methotrexate and itching, these may cause itching, which can cause a bacterial infection, a secondary infection if we scratch them. So use cool solutions. If you don't want to be too hot, cool tap water may help with the skin. All right, we're going to go on to burns. Give me 1 second here while I take a break, and I'll be right back. Okay, we're back and talking about burns. So burns, this is just tissue injury caused by either, they can be either thermal, which is can be hot or cold. We're dealing with hot here. And the most common cause other than injuries and fires can be scalding injuries. So keep your hot water heater at its lowest point. Make sure that the handles to pots are away from the stove so kids don't pull hot water down on themselves. We can have chemical burns. These can be either acids or alkalines or organic compounds. Electrical current, this is generated either, some sort of shock can cause an electrical burn. Radiation, this is either radiation therapy or sunburns, or if you're in an area with thermonuclear power, it could be radiation from there. And smoke and inhalation injuries, this is the inhalation of hot air or noxious chemicals, can cause damage to your respiratory tract. So chemical burns, to treat these result in tissue injury from destruction from acids, alkalines, or organic compounds. We should remove the chemical as quickly as possible. If we have dry chemicals on top of the skin, they need to be brushed off. Protect yourself, but you can brush them off. May need remove any clothing that contains the chemical. We need to use copious amounts of flushing of the skin, so copious amounts of water or saline to remove it. Alkaline burns are hard to manage because they cause protein hydrolysis and liquefaction damage occurs after the alkaline is neutralized. And tissue destruction may continue for up to 72 hours after a chemical injury. Results in injuries to the skin, eyes, respiratory tract, and secondary liver and kidney issues can result from large chemical burns. Smoke inhalation injuries, there are really 3 types. Carbon monoxide poisoning can happen without a fire. Homes should have carbon monoxide detectors because this is odorless, colorless, you can't see it, smell it, it just happens. When you inhale, CO2 causes hypoxia because you have a shift in your carboxyhemoglobin. You have carbon carbon hydroxyhemoglobinemia, say that 3 times fast, and death. So your carbon dioxide, or carbon monoxide rather, has I think it's a 10 times more affinity to the receptor sites than oxygen. You do not become cyanotic. You kind of get that cherry red. You actually look over oxygenated, but you're not. Treatment is 100% humidified oxygen or a hyperbaric chamber if you have access to it. And then we have inhalation injuries. So inhalation injuries above the glottis is caused by usually hot air, steam, or smoke. And this is mucosal burns to the oropharynx and larynx. This swelling can be extremely fast and results in a mechanical obstruction. So the swelling can actually close your airway, and it can occur very quickly. This is a true medical emergency. If you suspect an inhalation injury, you want to intubate early. Signs of an inhalation injury is the presence of facial burns, singed nasal hair or facial hair around the nose and mouth, hoarseness, painful swallowing, darkened oral or nasal membranes, the presence of soot around the nose can indicate that you have a injury above the glottis, and again, early intubation is best. So injury below the glottis, our injury is related to the extent of the injury is related to the exposure, the length of exposure to smoke or toxic fumes, and the heat related to that. So then it can manifest in respiratory distress syndrome, and can be can be a medical emergency. Electrical burns. The severity of the injury can be difficult to assess by looking at the initial at the surface injury. Usually, this will have it has a tract from where the initial electricity, and depending on the complications, depend on how the electricity travels through the body, and it can damage tissue along that track, right? So the severity of the injury depends on the amount of voltage, the tissue resistance, the current pathway, so how did this travel, the surface area, and how long they were exposed to this. Patients with electrical burns are at very high risk for dysrhythmias and require cardiac monitoring. And they may get severe metabolic acidosis and myoglobinemia, so they are at risk for kidney disorders, who will need to get plenty of fluid to flush out the kidneys so this doesn't become a problem. Classification of the injuries, so the severity is determined by the depth. We used to, and I guess I'm old school, so I really hate this slide. First, second, and third degree. The newer terminations are the newer terms are superficial partial thickness, deep partial thickness, and full thickness. So we used to say first, second, and third, and then there's also a fourth degree. There's a pretty neat picture in your book of what appears to be, to me, an electrical burn, but it's pretty severe down to the bone. So the superficial, so your first degree or superficial partial thickness affects the epidermis only. These are some of your radiation burns, your sunburns that don't result in blistering. You can have a thermal burn where you just get red, but you have no blistering. Your deep partial thickness are burns that extend into the dermis. So you have a destruction of the epidermis and into the dermis. You may have the peeling of skin or blistering. It can be a second degree. A full thickness is kind of is full thickness, or what we used to call third degree, goes into the fat or muscle or bone. Now they're kind of saying the fourth degree has this necrosis and down to the bone. So there you go. superficial, I mean, your full thickness or what we call third degree burns often result in like white statue looking skin, like it's no longer red. There is no pain in a third degree burn at the area of the third degree, right? Because you've killed off these tissues, the nerve cells all the way through. But you have quite a bit of pain as you go out and get into the second degree burns. It can be quite painful. And then as the healing can be painful as well. Um, Also, we need to look at the extent, so the total body surface area burned, and we'll talk about that here in the next slides. And then location of the burn. So there are some what we call critical areas. So the hands, face, hands and face are considered critical areas. Any circumferential burn, so a burn that goes all the way around. You'll see these. You see these a lot in child abuse, right? When you dip the kids in hot water. The problem with circumferential burns is that they can lead to a mechanical obstruction. So you lose the elasticity of the skin, and it becomes very tight. And it can. You may need to do an escharotomy, so where they cut open the skin so that allows for swelling, because you can actually get a compartment syndrome with that. Anything around the nose or eyes are prone to infection and circulatory issues. It could be anything around the mouth and nose. We're concerned about airway issues, right? So these are circumferential burns and burns to, serious burns, not a little burn to your hand, but a major burn to your hand, are usually treated at a burn center. Risk factors for these are older age, diabetes, cardiovascular disease can be risk for healing later on. Alcohol is involved in a lot of burns in this area, alcohol and drugs. We see that with meth lab explosions, honey oil lab explosions, alcohol. When you get drunk, you tend to lose some inhibitions and your judgment may be flawed. A lot of drinking occurs around bonfires in this area. So those can all be risk factors. So when we try to determine the total body surface area burned, we want to, we're talking about second and third degree burns. We don't figure in first degree burns when we're talking about total body surface area burned. The rule of nines is the most common estimation of body surface area burns that we use because it's so quick and easy. But we have the Ludbauer chart here just in case you want to see that. The Ludbauer chart assigns percentages to different body parts, as does the rule of nine, but the rule of nine really breaks it down into 9%, right? So the head and neck, front and back, so the entire head and neck is 9%. The arms, each arm, front and back, so the front of the arm would be 4.5, the back of the arm would be 4.5, so the whole arm is 9%. The anterior trunk is 18, so a multiple of 9, and the posterior trunk is 18. The legs are 18, so 9 in the front and 9 in the back on each. And then the perineum area is 1%. Another way you can figure out burns for, if you have you're trying to figure out the burn percentage on like kind of splatter burns or patchy burn areas, is you look at the size of the patient's palm. Oops, hold on. Lo siento, sorry about that. So you look at the patient's size of the patient's palm, and not your palm, the patient's palm, and that's considered 1% of the body area without the fingers, just this part down here. And you can kind of go over the areas and see what percentage they are. So emergency management of burns. So we want to, think about our ABCs, airway. If we suspect a above the glottis injury, we want to intubate quickly and, rapidly and early and fast. With burns from any sort of explosion, electrical burns, burns over 30% of the body, we want to assume C-spine injury until that's ruled out. Assess for the inhalation injury, so this is your airway, oxygen, vital signs and level of consciousness. We want to maintain the blood pressure greater than 100 systolic and urine output of 30 to 50 mLs per hour minimum. Maintain serum sodium levels at normal to near normal. We can use the formulas for fluid resuscitation. There's a lot of insensible loss in burns, so we lose that kind of plasma through the burn areas, and we'll talk about our formulas here in a bit. So we want to remove the clothing, cover the burns with a clean, dry dressing or sheet. In the field, the burns can initially be treated and you can get relatively good pain relief with cool water. So if your kid was becomes scalded from the boiling water from a pot, if you put them in a cool bath, initially, that is a good treatment. In the hospital, we don't use wet dressings anymore. If you're having trouble with getting pain management, you can momentarily use that, but we try to avoid the wet because we have these thermal regulations. Remember, the skin is responsible for helping with thermal regulation. So if we're putting cool water on there for pain for any length of time, they can become hypothermic. And a cold trauma is a bad trauma, right? These patients should have 2 large bore IVs and begin fluid replacement, and we'll go over the formula here in a minute. There are several formulas out there. I'm going to cover the Parkland. It's probably the most common used, but there's some, there's variations on that. And again, you'd have to consider comorbidities in that as well. Often you want to insert a Foley. These are for large, greater than 30% body surface area burns because ionos have become very important. Elevate burned limbs and IV analgesia. So this is quite painful. So we'll want to treat the pain consistently. So fluid replacement in the burn patient, we're talking about the Parkland formula for determining fluid replacement requirements for the first 24 hours in a burn patient. The Parkland formula says that you will give 4 milligrams per kilogram of body weight times the percentage of total body surface area burned, right? So if you have 100, if you're 100 kilos and you burned 50% of your body, then you would take the 4 times 50, because 50% of 100, right? So that's 200 or 2,000, so you'd be mLs. So you want to do 1/2 of that volume is to be given IV in the first 8 hours. So if your total fluid replacement, 4 milligrams per kilogram. Hold on, let me think for a second. Whoa. All right, I knew I was missing a 0 there. So back it up. So if you're 4 milligrams per kilogram and you are 100 kilograms, right? So 4 times 100, that's 400, and then times 50 is 0.0002. So that would be 20. Oh, hold on a sec. Yes. Okay. So we got that. So you'd have to take let's do this again 1 time straight through. So if you were 100 kilos, so you take 100 kilos times 4 mLs is 400, right? mLs. And if you burn 50% of your body, 400 times 50 is 20,000 mLs or 20 liters of fluid. And you want to give half of that volume, so 10 liters, in the first 8 hours and the second half over 16. So 10 liters in 8 hours. And this is from the time of injury. So if it took them 3 hours to get there, then you only have, you'll have to take that 10 liters, that half of the 20 liters, and divide that instead of, if it took them, if they're 5 hours from the injury, and it took them 3 hours to get there, so you need to subtract that. So it's from the time of the injury. Does that make sense? We're going to work through this in lab. Don't worry, I don't have you calculating this on the test, but you should know it. So we'll go over this in lab more with the math. Sit down and look at it. A lot of fluid because you lose a lot of fluid. So in the emergent phase, this is the resuscitative phase. So this is where we resolve any life-threatening problems first, so airway. This is your first 78 hours. You may see the beginnings of hypovolemic shock and edema. So this is why we do that fluid resuscitation, and we do so much in the first 8 hours and the rest over 24, and then fluid's more individualized after that. We can have hemoconcentration, so increases in H and H because we're losing all the fluid. That can put us at risk for clots. We have potassium shifts from the cell because of cell lysis, so you can get hyperkalemic. You have sodium shifts to the interstitium, so you can become hyponatremic. You can have so this is where we'll do the IV fluids, and the IV fluids are usually normal saline, or actually in burns the preferred fluid is lactated ringers. And this phase ends with fluid mobilization and diuresis. So as everything goes back to where it's supposed to be, you'll get a large diuresis of a lot of this fluid that we pumped in there, right? And you get restoration of normal cellular permeability and restoration of fluid and electrolyte shifts. So we'll want to monitor these patients closely and monitor their labs closely. The clinical manifestations of in the emergent phases, signs and symptoms of shock from pain and hypovolemia, may have blistering or not. Third degree burns actually don't necessarily blister. You kind of lose that top layer. You may have a adynamic or paralytic ileus. So in burns over, I want to say 50%, it might be 40. You'll put in an NG tube because you don't want to have aspiration of bile from this paralytic ileus. You may have shivering from being cold, so management of patient temperature and the dynamic temperature around them is important. May have also altered mental status. The complications include dysrhythmias from the electrolyte shifts, so we'll be doing patient cardiac monitoring, hypovolemic shock, obstruction of the airway, right from these, from the swelling of the supraglottal area. Below the glottis, we may have inhalation injuries. We may get renal ischemia secondary to shock, and that can lead to acute tubular necrosis from myoglobinemia, so the fluid also helps with that. All right. Some other complications in the acute phase could be wound infection. Infection is a common complication from burns. You may have impaired circulation if you have, especially from circumferential burns. And remember, the treatment for that is usually the escharotomy, so the cutting open of the skin to relieve that pressure. You may get confusion or delirium. It may even come combative and withdrawn at night. We're not sure why, but this is usually transient. You could get contractures due to reluctance to move from pain, or because the skin becomes less pliable and you get that where you actually can't move because the skin becomes so tough. And we can have the hyperglycemia stress, diabetes from increased catecholamines and crystal rising blood sugar. So you get kind of an insulin sensitivity secondary to these massive burns. So our nursing care in this area is wound care. So we want to keep these clean and dry. They may do skin grafting. We'll need to assess the skin grafted areas and the site of if it was an autograft, so it was removed from yourself. You'll need to assess the harvest site as well as the implantation site. If it is a donated graft, then you'll have to monitor the site. Any sort of purulent drainage around this site can be a sign of graft rejection or infection, and the physician needs to know immediately. Pain management is huge in the initial and follow-up phases. So with PCA may be good, patient-controlled analgesia. It gives you a basal rate of pain medication and lets the patient on demand with lockout intervals get their own pain medication. We'll need physical and occupational therapy. Nutritional therapy, we need to make sure that they have, there's going to be a lot of healing going on, and this requires a lot of a high protein diet, so we need to have nutrition adequate to promote healing. If the patient is unable to take an MPO, hopefully they can, and if they still have a paralytic ileus, that can be a problem, and they may need parenteral nutrition, but we want to do enteral whenever possible, feed the gut as much as possible. And psychological and psychosocial care. Patients with burn patients are at risk for post-traumatic stress disorder, so PTSD, that sort of thing. The rehabilitation phase can start as early as 2 weeks and last for 7 to 8 months, up to years, right? It begins when most of the burn area is healed, and this ends when reconstructive or corrective surgeries or procedures are completed. The goal of this is to regain as much function as possible. We won't know or have much of an idea of the kind of reconstructive, how close to normal we're going to get until the scars have healed and before we do reconstructive surgery. Often patients will be concerned that, oh, I can't wait to have my surgery so I can look like I did before. But we won't know that until what percentage of that, how we think we're going to look after that until after the scars have healed. So it's kind of a tricky psych thing of how you talk to them. You're never going to look normal again is not the way you address this. But that's something your surgeon will discuss with you after your wounds have matured, is an appropriate response to that sort of statement. So in the rehabilitation, we heal by primary intention or grafting. There is often scarring that goes along with these burns, sometimes quite significant and quite disfiguring, depending on where they're at. As the healing progresses, you may get itching. Benadryl may help with the itching. You can get contractures, so continuous and rigorous physical therapy and exercise is extremely important to help prevent contractures, making sure we're doing range of motion, keeping as much movement as we can, right? Purulent drainage from a graft needs to be reported immediately because it may be signs of rejection, and I covered that. So in the rehabilitation phase, we want to encourage active patient participation in care. Moisturizing cream can over healed areas. We want to use water-based moisturizing creams, and this is only over healed areas, not over an active open burn, right? Pressure bandages and garments may be used. You kind of see those burn socks. Again, exercise, PT, OT, And then attend to their emotional needs, fear, anxiety, guilt, anger, depression. We can help the patients and families cope. So this is a very serious complication, especially to major burns and especially to facial burns. Then you've changed a person's whole identity. So drug therapy through burn care, opioid analgesics for primary um, pain and for using them before dressing changes and physical therapy. You may get better response to physical therapy if you give pain meds beforehand. They may use Neurotins and NSAIDs as adjunct therapy. They'll need the life-saving tetanus shot, right, which is routinely given. They may need sedatives to control anxiety and help with sleep. Depression is a common complication for extensive burns, and SSRIs may become unnecessary. They may do antimicrobial topical agents, so topical agents over certain burns, or silver impregnated dressings may be used. Systemic antibiotics may be necessary only if there's sepsis or a dirty burn. Anticoagulants, so Lovenox or heparin for DVT prophylaxis, nutritional support, GI support to prevent stress ulcers. So they may do PUD prophylaxis, peptic ulcer disease prophylaxis. They may do protonics. Here's just kind of a list of graphs and their types. And factors that affect wound healing can be comorbidities and complications. So burn patients with immunodeficiencies, diabetes, cancer may have slower wound healing times. If you are burned, if you have nutritional deficits before being burned, that can be an issue. Getting any complications to the burn, so sepsis, bacteremia, cellulitis, anything like that will slow down healing. Impaired nutrition, impaired mobility, and not tolerating physical therapy can decrease your wound healing time. Moisture and incontinence can lead to skin problems in a person with already skin problems. Age, remember, older people kind of have that thinning of the skin, the loss of that structural integrity, and we also have other issues that can decrease our healing time. Mechanical stress, wound debridements may become necessary, but can complicate the wound healing. All right. And we talked about this a little bit, but the gerontological considerations. So normal aging puts patients at risk for injury because of their, I think this is in the wrong place. This is up with their skin stuff. Disregard. That's that.